5, and we'll do quick housekeeping and move on to our presentation. Well, good afternoon, everybody, and welcome to the Buncombe County Home and Community Care Block Grant Advisory Committee meeting. Today is Wednesday, December 13th, and we do have an agenda. We got a lot of things going on. So we have a great presentation ahead of us. So let's just do some housekeeping and get started after that with the presentation. So has everybody looked at the agenda? Are we okay with the agenda? Do I have a motion to approve?
Approve.
Second?
Second.
And the meeting minutes. Billy's great meeting minutes. Is everybody okay with them? Any additions, deletions, corrections? Hearing none, do I hear a motion to approve?
Approve.
Second?
Second.
Very good. Okay, excellent. So Jen, would you like to introduce our presenter, please?
I'd be happy to introduce Dr. McLean. There's nobody better in Buncombe County that's doing really great work for aging services and individuals. So Dr. McLean works with MAHEC and many other different hats that he wears. I'm so sorry I don't have his bio in front of me, but I have known Dr. McLean since I first came to Buncombe County, and he and Tasha Woodall were very innovative in the home-based primary care outreach in the community and just continued to partner alongside. So glad that you're with us and look forward to hearing what you have to share.
Jen, that's so kind, especially on, I think, your second to last day of work with the county. I feel so honored to be a part of it. And thank all of you guys. Like Jen said, I'm Will McLean. I am a family medicine doctor who mostly works with older adults over at MAHEC. And I work in a couple different settings. I'm part-time at Deerfield. But some of the work that is nearest and dearest to my heart is with our MAHEC Center for Somehow I got muted. Sorry, y'all. A lot of the work I do is with MAHEC Center for Healthy Aging, along with my co-director, Tasha Woodall, who's a geriatric pharmacist, who is really the brains of this operation. And I regret that she couldn't be here to talk with you guys today because you're gonna get skimped. But I'm just wanted to, at Billy's request, talk about our home-based primary care project, which is one of the main things that are one of the crown jewels of our activities at MAHEC Center for Healthy Aging. And am I okay to share a screen, you guys? I'll pull up just a couple slides that I...
Give me 1 second and I will make you a co-host so you can do that.
Awesome.
You should see that ability now.
All right, is everything showing up okay? Good. Yes. All right. So, y'all, we started the home-based primary care program, which the Buncombe County Home and Community Care Block Grant has generally supported for the past several years. Back in 2020, right before the start of the pandemic, and we started with a couple of thoughts in mind. One was we recognized that a lot of vulnerable older adults had real access issues to getting into clinic, whether it was transportation or lack of family support, mobility issues, all the above. We recognized there were a lot of folks that weren't getting in to get primary care. We also recognize that a lot of these folks, their challenges were far from just medical, that they had, as you guys well know, that do this work, these folks had a multitude of social determinant challenges that made life and aging the way that they wanted to, a lot more difficult. I think the third thing that we were hoping to put together with this program was this recognition that there is such incredible work being done by aging services in Buncombe County that we really wanted to tap into. We felt like there was a lot of silo between the medical community and the aging services community, mostly the fault of the medical community. But we wanted to tap into all the incredible work that was being done that we felt like could bolster all of our efforts at helping support these vulnerable older adults. And then finally, we wanted to make the care that we were going to give to our participants, we wanted to make it look like they wanted to. So we instituted this patient priorities framework that comes out of Yale and Baylor, and really puts a emphasis on figuring out what people want as they age. And then instead of making the medicine, the medical piece, imposing our goals onto our participants, we wanted our participants' goals to come out and let the medicine and support those goals. It sounds intuitive, but unfortunately, as probably many of you can attest, that all too often it's ignored in our healthcare world. So we created this team, this interdisciplinary, interorganizational team, starting with medical providers such as myself, and we've got another physician and a PA that help us out, and pharmacists. So we've got 3 pharmacists that help with the team, and we go out as co-visits. So we go out and physician and pharmacist pairs to actually go out and deliver care at home. But we also got a nurse care manager. We've got an occupational therapist named Sandra Winter, who operates under the name Insightful Rehab. We partnered with the Council on Aging, who provides a resource specialist. We've got care managers and care medics from Mission Health Partners that help us out. We've got community health workers. MAHEC has an official relationship with BIPA, but we also use we team up with Kathy Avery's IFA clients as well, and then we use a project that Tasha, my colleague, helped found called the Social Bridging Project, which is where we help pair folks who are socially isolated with often with volunteers, often pre-professional or professional students that want to engage with their community. So we try to pair all these wonderful team members and their respective organizations and use their respective talents and backgrounds and institutional expertise to come together to care for our program participants in as holistic and meaningful a way as possible. When we go out, we try to make sure everybody has a crack at all the different resources. So usually we'll go out and our physician and pharmacist pair scout out the home, figure out what the patient priorities are, get a sense of what their medical needs are. And then each week we come back and we have an interdisciplinary team meeting where all those team members come together and discuss the needs. And to me, I think this is one of the where some of the magic of the program happens, because it's all one thing for us to be aligned in name, but it's another to come together routinely and discuss patient needs and figure out care coordination and that sort of thing. And so each week we have an interdisciplinary team meeting to put all our heads together and figure out how best to help our participants. And then from there we make community agency referrals. Sometimes it's Council on Aging specific programs. Sometimes it's Meals on Wheels. Sometimes it's other aging services around the county. And then we have an iterative process. So we're going out at least once a quarter. For our folks that are higher needs, we're going out more frequently than that, just based on what their needs are. And each visit, we're trying to re-go through that process of have their patient priorities changed, have their medical needs changed, how can we integrate the two, or are there other referrals that are needed. What has our occupational therapist discovered? How can we get them some new DME, a new grab bar, a new shower chair, that sort of thing, fix a leak in the roof. We have grown a fair bit since we started. So over the past, we currently have a census of about 127 patients. We've worked with over 248 people since we started. It's a diverse group. We serve a percentage of folks who consider themselves BIPOC above the Buncombe County average. It's a relatively older group, as you can imagine, at 77 mean years of age. But we've really got folks of all ages. I shouldn't say all ages. We really focus on folks over 65, although we do have a couple of folks that are Medicare eligible that are in their late 40s. But to be in the program, you do have to have Medicare. Almost all our patients have lots of different medical issues, as you can imagine. Cognitive impairment is a big one, but also mobility challenges for a host of reasons, or another medical condition that we often see. At times in the past 3 years, we have experimented with going outside our county borders, but at this point, we are completely just serving Buncombe County. Being part of MAHEC, I think it's important for me to say that education is sort of a cornerstone of what we do, and our home-based primary care program is no different. So we host a variety of learners, and our hope is that seeing this, what we think is an innovative program that we're proud of, gives them an opportunity to see alternative ways that we can care for our communities. But we host family medicine residents, internal medicine resident doctors, pharmacy residents, as well as high school students through our the MAHECs and the Western Carolina Medical Society's joint N3P program, which is the Minority Medical Mentoring Program, and we have high school students that are coming from marginalized backgrounds that are interested in healthcare professions and are looking for shadowing opportunities. So we're lucky to have some of those high school students come out as well. One of the things that we pride ourselves on is we do seem to, we all know how much healthcare costs these days. And it's an important part of inflation and increasingly expensive aspect of all of our lives. And so anything that we can do to help save our system money, we are for, especially if it improves quality of life and good care. And so we are proud to say that these holistic efforts not only seem to improve people's lives, but they also seem to reduce their utilization of the healthcare system. So based on some Mission Health Partners data, at our looking at our patients, we seem to be saving the system around $469 per member per month when we last looked at that. So ultimately, saving the system several $1,000s a year, which if you're a healthcare economist, you know that's not small change for programs looking at impact. So we're excited that all these efforts coming from different parts of our community are seem to be helping the system. We are so grateful for the block grant itself, and the block grant itself it really helps keep our operations going. I just want to say a couple things about our integration with the or what we do for our block grant dollars. And primarily we have established a partnership with Adult Protective Services and people that have come through the APS system that don't have firm access to primary care are referred to us. Folks in the CAP-DA program that may not have good access to primary care or don't have routine visits with their established medical provider. We can come in and help with that and help do some of the paperwork necessary to help keep them enrolled in the program. And then we are also available, especially with our pharmacy team, available to help with medication management for APS clients.
What's CAP-DA?
CAP-DA, great question. CAP-DA is it's a community alternatives program. I'm forgetting what the DA is at the top of my head, but Jen will help me out.
Disabled adult.
Thank you. But the CAP program helps provide paid caregiving for patients in the community that may otherwise be at risk of needing long-term care. Does that help? Does that make sense?
Yeah.
Awesome. Good. And so far we've got 17 of those patients in that total census that I mentioned that are coming from the county, and we've helped with 27 referrals so far. Good. Let's see, timing wise, maybe got a couple more minutes. So just to talk about challenges. As you can imagine, we are a small program. So even though we've got 3 different medical providers, this is just a small part of what we do on a weekly basis. So I'd give a half day a week. My colleague, Dr. Dowling, gives 2 half days. Our PA, Kelsey Hines, gives 2 half days. So altogether, we're about 0.5. Sorry, we're 5 half days per week, or about 1/2 FTE going out and seeing 127 of these high risk patients, and that certainly limits the number of patients we're able to see. We mostly, aside from our relationship with APS, we mostly see patients that have been referred to us from within the MAHEC system. When we have capacity, we do take outside referrals from other physician offices or community service agencies. But based on demand, sometimes we're just limited to based on the amount of providers that we have. Sometimes we're limited just to MAHEC and APS. Fee for service, the way our healthcare is currently paid for, where we get paid by the number of visits that we do or the number of procedures that we do, certainly a ongoing challenge, as you can imagine. Going around, the county does not make for seeing a high number of patients at any given time, and if that's the way that you're paid, it is hard to generate revenue that way. That being said, because we're low overhead and we are generously supported by the block grant, we're able to get by. But as I'll talk about in a little bit, there's some ways that the healthcare system could be reorganized to help support programs like this that seem to help the system better. I think the last thing I'll just touch on is many of you may be familiar with the term accountable care organization. For others of you, this may be a little bit of an inside baseball reference, but we have these organizations within medicine that help pay for value-based care. And it used to be that there was only one game in town, that was Mission Health Partners, and they had one set of quality metrics, and they would pay, in addition to those fee-for-service dollars, they would help pay for different quality metrics and try to take stabs at helping programs like this since and devote resources like their care medics and care management and that sort of thing. They are now no longer the only game in town, and there are a host of different accountable care organizations that each have their own standards, each have their own set of patients. So you can imagine trying to figure out which patient belongs to which accountable care organization, and what resources are available to those patients can be a challenge and present a headwind to trying to take care of these patients. But I thought it was worth mentioning. Despite those challenges, there are a lot of opportunities. Namely, there is just a ton of need out there. I know that most of you guys that work in the aging space can attest. Just to put numbers on it, when PACE was first started, looking at between Buncombe and Henderson counties, I think there were something like 4,000 people that were thought to be potentially eligible for PACE services. And I know there's some expansion, but PACE itself, which I should say we're not competitors. We see I see PACE as another wonderful strategy to helping vulnerable older adults. But just to put in perspective, I think PACE for a long time has had a capacity of around 200, 300 patients. So a lot of need. We see it every day when we get calls from other doctors' offices that have heard about the services that we provide, or other aging services that have clients that they see as isolated in the community and having a tough time accessing services. So a lot of demand out there. We think that counties outside of Buncombe would also benefit from a model like this, and that's another opportunity for continued growth. Just to say out loud, things that we would love to be able to engage with more over the next 5-10 years. Certainly, you can imagine that aging adults are not the only people that could benefit from these services, these more intensive wraparound services. That there's a large Medicaid-only population that's at high risk, that uses healthcare services a lot, that could benefit from care that met them where they were, are intellectually disabled. Intellectually and developmentally disabled community also is another population, another community that would benefit from these services. So we'd love to keep seeing expanding who we can help. Telehealth is going to continue to be an increasingly important part of what we do. We are working on integrating more behavioral health services into the work that we do. And then finally, you can imagine that we see a lot of acute care needs. So a lot of folks that have to come in and out of the hospital that for conditions that currently need hospitalization, but are not so acute that if they were surrounded with the right resources, that we could potentially set up more of a hospital at home scenario, which in other communities has been able to has been a real boon, both in community satisfaction and saving the healthcare system money. So would love to kind of continue to work to get our toes wet in that world too. So that's it. I'm sorry, I know I covered a lot and probably still took too much time, but depending on y'all's agenda, happy to answer any questions.
Dr. McLean, this is Susan Sheemer. I just wanted to confirm that on the block grant funding, you have 17 current individuals. Is that correct?
That is correct based on a conversation I had earlier today.
Okay. And can you just quickly explain, when you go out to visit these folks, what does the team look like? Is it yourself and a physician and who is it?
Yes, it depends on the day, but in general, it is a medical provider like myself, a pharmacist, and then we may, depending on the day, we may have some learners coming along too. So it may be a family medicine resident, it may be one of those M3P students I mentioned, some variation on that. Occasionally, I'm going out just by myself on admin time if we need to try to work somebody in acutely, that sort of thing.
So I am super crazy excited about hearing this because I am not representing the VA. I'm actually off the clock because that was a requirement required by my employer. But when I am working, and about 30 minutes ago, what I was doing is I'm a medical provider. I'm a nurse practitioner in home-based primary care at the VA.
Oh,
and
that's awesome, isn't it?
And so I work for the Asheville area. And so I know a lot about the minutia of home-based primary care. And I tell you what, I go in and I see my patient and I see their spouse and I'm like, oh, they need what we're doing for the husband, but the wife. And so this is amazing. I'm so excited to hear about this. And I do have a couple questions.
Absolutely. And Melissa, I should have given credit where credit's due, because the VA was a huge inspiration for us. Y'all have been doing this for a long, long time, since the 70s, I believe. And
Yeah.
so, forgive me for not saying that too.
No, I think that's awesome. I mean, I think a lot of the things that you explained are what we do. And off the record, I wish I could get my pharmacist to go do a home visit with me. Maybe one day.
I do love it. Yeah, it's a game
Be
changer
helpful.
for us.
So how many are you seeing any patients virtually? And is there any plan to use like iPads or any telemedicine in this patient population?
Yes, we have on occasion, and we've talked a lot about integrating it further. And I think there are a lot of opportunities there for us at various times, especially during COVID. We have at various points used some of the Mission Health Partners care medics to go out and
Yeah.
I should preface all this by saying, we find that by and large, a lot of our participants are savvier than maybe people would give them credit for as far as accessing telehealth. But there's still a lot of people that need extra support. Either they don't have good access to broadband, or their comfort the technology is not there. So for those people, we were having Mission Health Partners care medics go out and actually have an iPad, and so that we could see folks that way. I think we haven't been consistent with it because that in and of itself presents some logistical challenges and coordination of schedules. And we've also settled into more geographic roles that make seeing our folks a little bit easier at any given time. And also, I think too, just that provider FTE limitation, that we're pretty consumed with seeing the folks that we're seeing in person. And none of the three of us have had the real capacity at this point to like break off and do a day of just telehealth, even while acknowledging that it would expand capacity some.
Yeah, it is a challenge too. I mean, even in the geographic area that you guys are serving, which is also the geographic area that I serve with access to a signal, that is something that we really need to work on in our community.
Well said.
Because even in West Asheville, there are like major problems with the signal. Then the two other questions I have is one is about, do you assist with getting medications at all and like obtaining the actual prescription? And then do you have a overhead or cost for travel?
Well, so for the medication, as of now, we don't directly transport medications except for, very rare individual circumstances. Rather, we rely on a lot of the local pharmacies that do pill packs and do delivery. And no doubt those have been a huge boon. So Sona, B&B, Carolina Mountain, and Inky Candler, all those guys fortunately have pretty well developed home delivery systems that we latch onto. Forgive me, I've already forgotten the second part of that question.
About travel, I'm wondering, do you guys use
Oh,
your
travel.
vehicles? Do you pay for your own mileage? Do you have to pay, have a cost to cover that? How do you pay for that?
Mayhec does cover the mileage cost if you request it. I typically just drive, but my two colleagues we've got some Mayhec cars too that are just part of the fleet that they'll check out and use, and that works.
Awesome.
Well, I hate to be a spoil sport here, but
I've already taken way too much time. I really appreciate you guys, and
no. We really appreciate you and all the services that you provide to the community, Dr. McLean. We really do appreciate it, and we know your time is limited, so we are very happy that you were able to join us today.
Well, me too. Thanks so much for giving me the opportunity to talk, and I can't tell you how appreciative we are. It truly, especially within the limits of that fee-for-service medicine, the block grant really is critical to helping us do our work. So we are so appreciative of Buncombe County.
Well, thank you.
Thank you, guys. Have a good evening.
Thank you, you too.
Thank you, Dr. McClain. Susan, while he's transitioning off, I'd just like to say I think he's very humble. His work and the work of his colleagues is life-changing for the clients that we serve. We see it every single day. Many physicians would not go into some of the homes that we actually go into, and Dr. McClain goes every single time, provides care and support. We had a client who did not want to even let somebody in their home. And Dr. McClain went out and said, "That's fine. We'll see you in this camp chair outside." And I cannot speak to how wonderful and how lucky we are in our community to have Dr. McClain and the others that do this work, because it is life-changing for clients who would not be able to access the service otherwise.
Well, Jen, we wouldn't be there without you. And so I can't say enough about the good work at being done over at APS. I mean, those caseworkers are just so tireless and such huge resources. So thank you for the kind words, but right back at you. See you.
Can I ask a question, Jen? It's wonderful that we do this. How much more of it do we need? There are times when there just isn't enough bandwidth in what they can do to meet your APS needs.
I think that they're able to meet our APS needs for those 60 plus. The issue that we have is, as you know, Dan, APS is 18 to however old someone is. So we have that 18 plus, and these funds are only specific to those 60 plus. And that's really where their capacity is at Mayhec as well. As you heard Dr. McClain talk about the age parameters that they have. And so we have clients that are 30, 40, early 50s. We can't use these funds to support them, and they can't, many of them can't leave their home. And there's not a lot of other great options out there right now for individuals that can go into the home to provide care. Mayhec was very innovative. It sounds like like they followed the footsteps of what the VA had been doing. But we still have a gap for those that are between the ages of 18 and 60.
Okay, thanks.
And just, so sorry to follow up on that. Just a couple of additional comments. The grant funds that you all use, it's all through Buncombe County Supplemental Aging Funds to support them. It does not meet the criteria for block grant funding. The other thing is that it does do the home-based primary care piece that Dr. McLean spoke about, but their application has also included things like completion of an FL2, which is a form that has to be signed for someone to get to move into a nursing home or a long-term care facility. They've also done COVID vaccines for us, and they've done TB tests. So these one-off things, a tuberculosis test, or these one-off things that people have to have before they can move into long-term care. And we've just been very fortunate to have that partnership to be able to kind of move that process along.
Well, I'm very glad that we had we were able, or I should say, I'm very glad that Billy was able to schedule Dr. McLean for our meeting today. So switching gears, folks, the application. Now, I sent out the application on Friday, and I hope everybody went through it. Jen did a great job with reorganizing the section that's about, what's it called? Oh yeah, the program proposal, which starts on page 3. And if you go all the way to page 5, we talked about the units of service and that it would include all of the administrative costs in addition to the actual service. And then one thing I added after some thought and discussion with folks is question number 12. And Jen, you might not see this. I don't have it on my screen. I don't have it on my laptop, but I did add in the handouts a question 12. Does your program maintain a waiting list? And if so, how do you determine who is added to this list? And so Jen really educated me when we were talking about the application about wait lists. So Jen, can you kind of share what we talked about with the rest of the folks?
Sure. And Zach or Leanne, you're more than welcome to participate in this conversation, add any additional context. For years, the state has actually talked about whether or not to add wait lists. There's a prioritization tool that they drafted back in 2017, but ultimately made the decision it was not going to be mandated for providers to complete. There's a variety of reasons why people don't either maintain wait lists and why it's hard to require wait lists. Things like, and if you run a meal delivery program, do you only consider wait lists for areas in which you are having routes, or do you consider people who live outside of the routes on a wait list? If you run programs like, let's just say in-home aid, is it anyone who calls and says, I'm interested in in-home aid, or is it only clients who are eligible for in-home aid? Do you put those people on the wait list? Does that mean every single person that goes on the wait list has to complete the client registration form, which is the DOS 101, to make sure that they're actually eligible for the service before you put them on the wait list? If you're 59 and a half and you know that there is a wait list and you might want to be on the wait list at some point, are you eligible then to be on it, or do you have to wait until you turn 60? These are just a couple of the examples of why wait lists are challenging to manage. It's not to say that we couldn't do wait list requirements, but I think it's a longer conversation than a one-time meeting to say, yes, we want to require wait list. I think it's what does that look like? Does that require the DOS 101 to be completed? Does that then require that they input that information into the ARMS, that aging management resource program that they use for pulling down funding? How do you do it if you only serve a certain area because you have certain routes? Or is it the community at large that has that need? Zach or Leanne, would you add anything else to that?
Yeah, I would say too that the way that we can track it is if they do put their wait list in arms, but certain people like Mountain Housing, they actually have an in-house wait list that they maintain and update themselves. So they don't necessarily keep a wait list in arms. And with that being said, we can't necessarily, I mean, y'all can, as a mandate of receiving home and community care block grant funding through Buncombe County, y'all can mandate that a wait list is kept. But personally, as of right now, a wait list is a best practice. Whenever I go in to monitor, they may have an internal wait list. They may just not have a wait list at all. They may just, tell people try back later, or there's not enough demand for the service and they don't need a wait list. But there's just a lot of different factors that go into that.
And everyone, my thought process with adding the question was really to get information from the different providers. I'm not suggesting that at this point in time we mandate that they provide their wait list numbers, but it was just the beginning of a conversation with folks about, do you have a wait list? And how do you determine? And when my head started spinning when Jen started talking about all these different requirements and everything, and I'm like, whoa. So that question was really just, like I said, dipping my toe or our toes in the water of what is the demand for these different services.
I like the question and I like your thoughts on it in terms of a way to get more information and have begin a conversation and figure out where do we go with this, if anywhere.
I would agree.
So given that, well, I do appreciate that. And I've looked at these units of service reports long enough and continue seeing that column empty. So, it's a start. It's a start. So does anybody have any comments or questions about the draft that was sent out? Do we think it's acceptable to finalize and send out come January, Jen?
Yeah, January 16th, the application will go live. Just as a quick reminder, the strategic partnerships team, in collaboration with grant managers of other different programs that the county, is doing a in-person event, and that's January 10th, right, Billy, with a snow date of January 17th.
Yes, yeah, January 10th from 4 to 6 at 200 College Street. So it's a grants fair for people to come and get their nonprofit organizations to come and learn about the different funders and get their questions answered.
What's the date again? I'm sorry, I didn't write it down.
It's Wednesday, January 10th from 4 to 6 p.m. at 200 College Street, where TD Bank is.
Okay.
And Jen, would you, are there going to be like tables there? Are you going to be like manning this, representing
Well,
this
I
group?
won't be, but Billy will be. Billy will be.
Oh,
your
Billy, I'm sorry,
director.
Jen.
I'll be there. Originally, they were gonna have where people could do presentations and sit down, but there's probably gonna be a lot of people coming, so it's gonna be more like a open house is how they're describing it. So people can come whatever time they like from 4 to 6. But yes, I'll definitely be representing HCCBG and BCSAF, Buncombe County Supplemental Aging Grant. So I'll be there.
Okay. So going back to my question about the application. Are we okay with approving the application as it stands here?
I'm
Looks good to
comfortable
me.
with it.
Yeah.
Okay, I guess we should put this up for a vote. Everybody in favor of the current application? Say aye.
I,
Any
Aye.
opposed? Hearing no opposition, I guess the draft is now final for the fiscal year 20. Oh my goodness, 2025. Excellent. Okay. Now, the units are going on to the units of service. I'll close out the application so I don't get distracted over here. Going to the supplemental funding and the units of service. As you know, we're having our meeting a little early, so we don't have November's information, but we do have October's. And as you can see, some folks say on the units of service, for example, fiscal legal is has pretty much been moving right along. And in the percent of grants served, it's 119%. So what I'd like to propose for the group is December 31st is going to be 6-month period, the end of the first half of the year, the fiscal half of the fiscal year. I'm not sure if folks will know, but they might. I'd like to kind of maybe hate to put things on Billy, but ask Billy to contact all the providers and say, at halfway point through the year, do you believe you have any funds you can reallocate, or do you have a need for more funding if we're able to get reallocation from another provider? Or even Jen, here I'm going to punt it back to you about the question about in-home aid at the county with level 1, 2, and 3.
A couple quick updates. I think we talked last time about the county was not necessarily going to apply for in-home aid. That decision has changed. We are going to actively apply for FY25. Anybody is also welcome to continue to apply. But we did just want to let the committee know that if you see an application, you may wonder, I thought we said that they weren't going to. We decided we did want to actively participate in the process for FY25. For FY24, the year we are currently in, you will see that level 3 spending has been pretty low. The reason that is because we actually found out that 4 of the clients that were receiving level 3 services, were actually receiving those by family members. And if you do a deep dive into policy, there's some deep qualifications on that. We felt like it just did not meet policy to pay those family members. So we moved them to county funds and off of block grant federal funds. And when we did that, we now don't actually have anybody in the level 3 funding pot to utilize these level 3 funds because we are not allowing for anybody else to be moved to level 3. That was a decision made a couple of years ago. And we had sent an email earlier this week to Susan requesting, can we move these level 3 funds to level 2, just still within in-home aid, because we are still serving level 3 clients. We're just serving them through the county funds, the same people that were on the service originally.
And so to confuse everybody even more, Jen's looking at the units of service report. And you'll see that Buncombe County Health and Human Services had a budget of $14,000, of which they've only used 2,000?
Yeah, $2,084.
Yeah. So what the request to the committee is, would you allow allocations within an organization, just not between organizations? Is that kind of the issue?
Yes, like how you all would like to handle that. For example, can the county do that? It would be similar, like if Mountain Care needed to move money from daycare to day health, or Mountain Mobility were to ask to move money from general transportation to medical. Can they do that? And just like approval of county staff, maybe in conversation with Zach, or do you all want to bring that back here for approval within the committee? They still have to do additional paperwork, but just how do you want that approval to happen?
Can I say something else about the units of service and backing up just a little bit? Because I mean, I'm wondering if we're actually asking the same question, because when you look at physical legal services, they're way over what we allocated to them. On the other hand, I don't think that's going to make a whole lot of difference in the services they provide, because they just provide services, and I'm sure they're allocating to us everybody over 60. Okay. But they have an awful lot of sources of funding, and I seriously doubt, as a matter of fact, I'm pretty sure if they don't get any money from us, any more money from us, they'll be fine. And I think that's probably different than an organization that is very dependent on us for providing its services. And, you know, if they have to reallocate from one to another, I don't have a problem with that. But I think we should also be taking into consideration whether how dependent they are on this funding to continue this program, or whatever program it is we're funding, if that makes sense.
Eileen, I think that makes a lot of sense. And what I would like to do is, rather than make a decision today, is to have Billy survey all of our grantees and then we can collate all that information and get it out to the committee members for next month's meeting. And we would be able to then make a decision on reallocation. Plus, we've kicked the can down the road enough on that 40,000 that we got earlier in the year. So I think your point is well given. Any other comments or questions about that plan of action to have Billy survey all the folks and see what their funding needs are, and then next month make a determination of where money can be moved around and where that $40,000 can be best served?
I think that makes sense.
I just want to add, since I won't be here in future meetings, and it will take a little bit of time before the county is able to hire another program manager. I do just want to let everybody know that Ryan, who is the supervisor over the in-home aid program, and I met earlier this week and feel as though at least right now that the in-home aid funds will probably all be expended, whether that is county funds and block grant funds. Part of that is the reason that you see so much money budgeted and still in the pot right now in the Buncombe Service Aging funds is because we have just been adding more clients on. We couldn't add all those clients on at the very beginning. And so if we were to take the spending of all of our providers for today and multiply that out over the next 7 months, we believe that all of these funds, or very close to all of these funds, will be exhausted. And I share that because we also are budgeting that would mean if we were to able to maintain this many clients into next year, it would actually run about $630,000, which is about $150,000 more than we have allocated in the program right now. So I'm not saying that because that to impact future allocation. I'm just saying that as if you look at this right now and you see Buncombe Aging Service Funds have only spent 10% in-home aid, it's because we were spending down block grant, moving to in-home aid, moving to county funds, but also as more people get added on, that cost is continuing to rise. So we do anticipate very close to spending all of it. And I know that's where we've taken a lot of money at the end of each fiscal year. I think it's important to know that at least right now, it looks like those funds won't be available, at least not a huge chunk of them available for reallocation.
Can I ask a question, Jen, and just a general question in terms of having that program in-house? Has that been, have you felt that that's a benefit? Obviously, there was work to get that going, but is it good to have those resources in-house, or does it not matter?
I think that for the majority of the staff that work in adult and aging services, they would say it's been really good. It's been really good because, as a quick side note, we also oversee another in-home aid program that's called the Social Services Block Grant Funding. And those funds are really what we use to support clients under 60. And so what we've been able to do is by having both funding sources, we can really manage better which client needs to go on which funding source. We also have some additional capacity, of course, at the county that maybe other organizations either may not be able to tap into at all times. Again, that's not to say it couldn't go back out into the community if there's an organization that's interested in applying. But I do think, at least for the time being, it seems like it's been a really good fit. We've also been able to have the staff to do thorough reviews. We've utilized that draft prioritization tool for every single person on the wait list, come up with a number, aligned them based on need, et cetera. But the need is great. In-home aid, it continues to be a need that people in our community have, and the demand is definitely there.
Thanks.
And Jen, I'll be looking for Ryan's application and his explanation of why the service should stay with the county. So you give him some quick side notes before you run out the door. I just wanted to take some time. We're wrapping up. It's 4:28. We have 2 minutes. And I just wanted to let everybody have an opportunity to wish Jen well.
Yes. Good luck.
Good luck, Jen.
Look, thanks for everything.
Good luck, and what
Yes,
an
thank you.
exciting opportunity.
Yep.
Excited for you.
Best of luck. I'm excited for you also.
Thank you for helping us navigate these things, of which I have not a clue, and things that not being in the field, you really help clarify a lot of stuff for me. So I appreciate it. And you're my security blanket, and I'm not sure what I'm going to do now because you'll be gone.
You'll be missed.
Well,
I just want to say thank you all so much. This has definitely been one of my favorite groups and committees to work with. Each of your passion, knowledge, questions that you answer, I think just makes this group better and does really good work in our community. I know Leanne and I have talked about that before, how wonderful this group of individuals are, how lucky we are to have each of you and your interest in this, in allocating these funds and doing it in a way that is really equitable across the county. I just want to say, I'm really excited too about where I'm going. I'm hopeful it continues to fuel aging services across the country is my hope now, but staying in touch with those here in Buncombe County to make sure they know of things that are coming up on the horizon. So
great.
Excellent.
Oh, Jen, we're going to miss you, but we wish you the best.
thank you all.
Anything else? Final comments, questions, concerns? If not, I will wish you a good evening.
Thanks. Good night, folks.
Thank
Good night.
you.
Good night. Thank you.
Happy holidays.